Madam, good morning.
Sir, good morning. Good morning, sir. Thank you.
How are you, Amma? Bavanara?
Sir, good morning, sir. Good morning.
Good morning.
మ్యూట్ చేసుకున్నా అందుకోసం వినిపించలేదు. థ్యాంక్
యూ. నేను మీకు చెప్పినట్టుగా 10 మినిట్స్ ముందు వస్తానన్నా వచ్చేసాను.
సరిగా మీరు ఎక్స్పీరియన్స్ పంక్చువాలిటీ ఇంకా
పీపీటీ రెడీగా ఉంది కదా మీ దగ్గర?
సార్ రెడీ ఉంది సార్.
రైట్, నేను చెప్పినప్పుడు ప్లే చేయండి అది.
ఓకే ఓకే సార్.
ఫస్ట్ స్క్రీన్ పెట్టచ్చు, దాంట్లో ఏం ప్రాబ్లం లేదు.
ఓకే సార్.
నేను స్టార్ట్ చేసినాక అది మీకు చెప్తాను, దెన్ యూ స్టార్ట్ ప్లేయింగ్ దాట్.
గుడ్ మార్నింగ్ సార్.
మిగతా వాళ్ళు ఎవరు మాట్లాడలేదు కదా యూట్యూబ్లో వాళ్ళదే మాట్లాడు
అందరి మ్యూట్ పెట్టుకోవాలి.
మ్యూట్ అన్మ్యూట్ ప్రాబ్లం
గుడ్ మార్నింగ్ సార్. సార్ సార్ యూట్యూబ్ అది స్ట్రీమ్ ఎండ్ అయిపోయింది సార్. ఇంకోటి పంపిస్తా. కాకపోతే జూమ్ ఆన్ కానీ సార్ పని చేస్తుంది సార్. అడ్మిట్ అంటున్నా చూడండి, వస్తుంది ఇప్పుడు.
పక్కకు వచ్చేసి అయినా మాట్లాడాలి, హాఫ్ అన్ అవర్ మాట్లాడాలి. వాళ్ళందరూ వెళ్ళిపోయాక మాట్లాడదాం. కూర్చొని చెప్పండి. మీటింగ్ ఉంటారు మీరు వస్తారా? నుంచి అక్కడ మెటీరియల్ లాజ్ అదే జూమ్లో అయితే చాలా మంది ఇచ్చినట్టు మళ్ళీ
జూమ్ వచ్చి
44 మెడికల్ కాలేజ్ ఉందా మీకు? మెడికల్ కాలేజ్ ఉందా మీకు?
Dear participants, please mute yourself. విద్యాసాగర్ లైన్లో ఉండు, నేను అన్మ్యూట్ చేస్తా, ఓకేనా? నువ్వు చేసుకో, నేను చేస్తా. లేకపోతే నువ్వు అన్మ్యూట్ చేసుకొని మాట్లాడు. నువ్వు ఇప్పుడు అన్మ్యూట్ చేసుకో, ఓకేనా? రైట్. సార్ గుడ్ మార్నింగ్ సార్, వెరీ గుడ్ మార్నింగ్. ప్లీజ్ జాయిన్ ఇన్. సేమ్ లింక్ సార్, సేమ్ లింక్. సేమ్ లింక్ సార్. అబౌట్ 40 పార్టిసిపెంట్స్ సార్. మన యూనివర్సిటీ వరప్రసాద్ సార్, రిసోర్స్ పర్సన్ సార్ మనోహర్ సార్, సెంట్రల్ యూనివర్సిటీ. సార్ is joining sir. Now he is going to start sir. Please join. Join. నేను yes sir, I told to sir, but sir is not joining. Again I called to sir. Okay sir. Register sir. Register sir. Please join sir. Please join. Your presence is most because of our college purpose. That's why sir. That's why sir. Please speak few words for 2-3 minutes. Thank you. Thank you. ಮತ್ತೆ
Madam, you can start, madam.
Sir, start, sir. Just wait for principal, sir. Start, sir. Vidyasagar?
Madam.
Yes.
Madam, can I continue?
Continue. First, invite the guests.
Okay, madam. Okay, madam. A very good morning to all of you. I wish to you welcome the national level
Yes, sir.
webinar on
Start,
Indian
I
health
think,
policy
please.
and evolution of
Invite
pre and
people.
post COVID-19 period. We already know we are moving lockdown situation to unlock economical situation. At this present, we would be identify the individual survive in this pandemic situation by taking precautions of COVID-19. We hope this webinar will bring you a great knowledge and suggestion to all of you. For the reason this webinar is structured by the convener. So before the beginning of this webinar, I would like to invite our eminent personality who always give me a full support from the administration and as well as the academic persons. The chief guest of this webinar, Sri T. Chiranjeevulu sir, IAS, Vice Chancellor of Satavahana University. He may join this meeting for the time. Next, I would like to invite our special guest, Professor T. Bharat sir, Registrar of Satavahana University. And I would like to invite today President of this webinar, Dr. Mohammad Jafi Johari sir, Principal of Arts and Science College, University, Satavahana University. Now I would like to invite co-convener Dr. M. Varaprasad sir, Associate Professor of Economics Department, and Dr. D.Rajender sir, Assistant Professor part-time in Department of Economics, Satavahana University. Now I would like to invite the convener, the head of the department, BOS of Department of Economics, Dr.K.Srivani Dr.M.Varaprasad, who has been construct this webinar on the purpose of the pandemic situation. Now I would like to invite Dr.K.Srivani Dr.M.Varaprasad for receiving this accept to continue this webinar on the proceeding the inviting all the dignitaries and resource persons by continuing this webinar. Madam, I request you to continue this webinar, madam, by your under vision. Hello, ma'am.
Okay.
Hello, ma'am.
Yes, sir, I am here. Just 1 second.
Okay, madam. We are happy to share you. We had receiving about.
Sir? Zoom దిగేసిరా sir? Okay, very good morning to all. We are very glad to, the Department of Economics is very glad to announce and organize this national level webinar on Indian health policy and evolution of pre and post COVID-19 period. So this topic is very reflected on current situations. So that's why the department is decided to organize this webinar on health policy. So in this regard, I'm very happy to welcome you all to this national webinar. And we have our Department of Economics, University College of Arts and Social Sciences, Satavahana University Karimnagar, Telangana State. So in these pandemic situations, we have saw so many situations regarding the health and healthcare economy, and so many related the health conditions of the people and how the health economy is there in the India and all over the world. So in this way, so the Department Economics is have the very eminent professor and the former faculty of the Satavahana and founder of the Satavahana University, eminent resource person and well-known person, well-known speaker, is an eminent speaker. We have the very lucky to have this resource person in this webinar. Now I would like to invite Professor. I very much invite the all our register of this university, vice chancellor of the university, Shata University, principal of University College of Arts and Social Sciences, Dr. Mohammad Jafar Jerry, and my department colleagues, senior professor Dr. M. Varaprasad sir, D.Rajender, and my dear research scholars of economics, students of economics, and other faculties of students and other faculties of professor of this university. I warm welcome to you all, and I request all the participants please mute your mic, and you have the hour for questions and discussion to the resource person, Professor Manohar Rao sir. Definitely this program will help and will useful to you, enlighten your knowledge in this topic. So now I would like to invite Professor J.Manohar Rao sir, eminent personality and distinguished personality in this our country and also international personality. So I would like say brief biodata of Professor Manohar Rao sir. Professor, he was the professor of economics in the School of Economics, University of Hyderabad. Before joining University of Hyderabad, taught at Sri Venkateshwara College, New Delhi University, and Shatavahana PG Center, Usman University, Karimnagar. He presented 2 papers and chaired 2 sessions in Global Interdisciplinary Business Economics Advancement, GIBA 2014 conference, University of South Florida, that is 16 to 18 period. And sir visited Idaho State University, US, on invitation and presentation paper on health care in India policy imperatives. He is a member of ICSSR New Delhi as a national subject expert of economics, member governing body Madhya Pradesh Institute of Social Sciences Research, Ujjain MP, member BUS Indian Institute of Management Indore, and member committee for advised studies in research center for studies in science policy, JNU New Delhi, member board of studies RSTM University Nagpur. Sir is a visiting professor Rajiv Gandhi University, Itanagar, Arunachal Pradesh. Sir is a visited faculty Addis Ababa University, Ethiopia. Sir visiting consultant, African Economic Research Consortium, Nairobi, Kenya, and PhD Economic, JNU, MPhil Science Policy, JNU New Delhi. Sir has a specialization development economics, technology innovation, and technical change, globalization, health economics, international economics. Sir has a teaching experience 30 years, taught advanced economic theory, research methodology to MPhil, and theories of economic growth, microeconomic theory, and development economics, comparative economic systems at University of Hyderabad. And sir visited a faculty consultant at Health Economics, African Economic Research Consortium, Nairobi, Kenya from July 8 to 2006 to 20 August 2006 for CMAP program. Sir, as an associate professor, taught health economics, advanced international economics, and developed planning at Adidas Abba University, Adidas Abba, Ethiopia. So these are all. Sir has a vast experience in teaching. This is a very brief, and sir has research guidance. Sir, PhD, three PhD scholars are awarded. One under progress PhD, and one MPhil is 11 MPhil scholars are awarded in Sir guidance. MSc 6 awarded AAU dissertations, BA senior essay 12 awarded AAU. Sir has published 3 books on different issues of globalization, technologization, competition, and another book is social studies, and another Sangika Samstram Ardhashastra Vibhagamu in Telugu, published by the government of Andhra Pradesh. Sir has these are the research towards the different issues in the society. Sir has forthcoming books also there, 2 books, Healthcare and Delivery Challenges of Biotechnology and the Japanese Pharmaceutical Industry. So SAR has published 30 national and international papers on various issues towards the healthcare and international trade and Indian economic development issues and policies in the globalized era, and so many in industrial structure and international competitiveness. These are all are the research papers. So many research. It is a very little bit is there. Papers are published in different research papers, international and national levels also. SAR has membership in professional bodies, life member in Indian Economic Association, life member in Indian Econometric Society, life member Indian Chapter of Sciences for the Policy People Society, Chicago, USA, and life member Indian Political Economy Association, life member Indian Academy of Social Sciences, and life member Andhra Pradesh Economic Association, and so member Delhi Science Forum, and member Forum of Philosophy for Social Action, New Delhi. So this is a very brief, sir. Sir has a very vast about so many papers, so many national, international personalities are has there. And sir, I very happy to have as a resource person to this webinar, and I hope all the participants and myself also will get the knowledge from you, sir. Uh, Thank you, sir, and I'm not wasting of your time, sir. Please, mic over to you, sir. Thank you.
Thank you very much, Dr. Srivani, for
Thank you.
allowing me to speak here.
Shall I?
Well, you can give the speaker's address so that I can proceed. Okay. First of all, I thank the organizers, the Department of Economics, University College of Arts and Social Sciences, Satavahana University, Telangana, from Karimnagar. I thank the incumbent chief guest who is yet to come, Mr. Chiranjeevulu, IAS, Vice Chancellor of Satavahana University, and special guest Professor T. Bharat, Registrar, and President of today's webinar, Dr. Mohammad Jafar Jari, Principal, University College of Arts and Social Sciences, Satavahana, and the convener, of course, who was so insistent on my presenting the webinar today. My special thanks to her, Dr. Srivani, and the co-conveners, Dr. Varaprasad and Dr. Rajender, who are also my very close associates for a long time. Now, I think Dr. Srivani, you can start my PPT. You can project it onto the screen.
Yes, sir. Yes, sir. Yes.
I'll start directly with the presentation.
Okay. Shall I invite Varaprasad, sir? Varaprasad, sir, is waiting.
For what?
Varaprasad sir, for speak some words interacting with you, sir.
Oh yeah, sure, sure. Why not?
That's it.
Yeah, please, please.
Prasad sir.
Sir, good morning to all.
Sir. Thank you, sir.
Sir, good morning to all. Sir,
Varaprasad,
am I
I
audible?
can't see you. You have
Am I-
muted your video.
Video is off, sir.
Why? You don't want to appear?
No, sir. I can. Just wait. Okay.
Yeah. Because
Yeah.
after a long time that you are appearing in front of me.
Okay. Thank you very much, sir. It's nice words from you. So, respected chief guest and other guests of the seminar, and keynote addressee, my teacher since post graduation, since 1995, is my guide, well-wisher, and first appointee in the Satavahana PG Center, the birthplace of Satavahana University Karimnagar. So Sir has a longing to in work to participate in various programs in Karimnagar. Madam has taught very less in the brief speech. Sir is a regular presenter in the television channels, ETV programs, as well as you can see his articles in Andhra Jyoti and various Inadu and various newspapers too. And I know because Sir used to share all his videos and clippings to us. And he is more comfortable and he's with the student faculty. So with this brief speech, I do not want to tell much about the program because Sir it's already late. So I request Sir to kindly take over the proceedings. Thank you very much.
Thank you, Varaprasad. Thank you.
Thank you, sir. Thank you. Now I share screen, sir.
Yeah. Now you share the picture.
Yes, sir. Yes.
Make it full screen.
Yes, sir. No. This takes some time.
Yeah. Yeah, that's it. You stop it there, make it full screen. Yeah, that's
Yes.
fine.
Thank you. Thank you, sir.
Right. Okay. Thank you all once again. And let me start with the topic today, namely Indian health policy and evaluation of pre and post COVID-19 period. And this obviously, is unexpected pandemic that has engulfed the whole world with not just health issues, but also many institutional changes that has garnered by this pandemic. And one such is, of course, the most predominant sector is health. So that's the reason why the current topic has assumed the greatest proportions of significance, and the whole world has taken uh, the view that unless we try to attack the pandemic on one hand, and at the same time we stabilize ourselves in economic life and social life while bringing institutional changes to the deep rooted malaise that has affected the whole world. So in that way, there are some plus points and the minus points. The minus points we'll take up later, the plus points we'll take first. And before that, I would like to, because in the short time which I'm going to cover the whole world and India and also our own Telangana region and including Warangal and Karimnagar districts. So it's a very big task and time is also very short, but obviously the presentation that I'm taking today, which I presented in an international conference in Michigan State University, and that I have abridged and tried to make it to local to the Indian conditions, and I'm sure you will enjoy. I'll try to interact with you. I thought, in the beginning that I'll make it kind of, uh, quoting from the textbooks and quoting from the references, but the time doesn't permit. I'll just directly go to the topic and I'll try to uh, tackle the issues that are immediately prominent and significant to us into day-to-day life while saving our lives in the pandemic situation and progressing forward, and how health policy has changed. So first things first. Now there is a controversy in the world, all over the world, that whether health is a public good or private good. And this controversy is being, in my opinion, deliberately rigged up by some private corporate interests that have actually exacerbated the issues more than the reality. That is because they try to make health as a commercial product. And now the most positive issue that COVID-19 has brought in is that health is not a commercial product at all. Health has no discrimination. It doesn't discriminate between caste, creed, religion, and region and nationality. It's universally applicable. Anybody can live, anybody can die. And obviously, commercialism doesn't save. You may be a billionaire, trillionaire, but you can't save your life unless you tackle the issue to the core. That itself, I think, is enough to prove that health certainly is not a private good. It is a public good. And obviously, at least now, the governments must open their eyes and realize that public should be given number one priority. Their health and healthcare has to be given predominant position, and they must be given access to the healthcare and health issues, whoever they may be, and develop facilities that are being shortened in countries like us. And even in the advanced countries, whatever level they have, like for example, when Obamacare was introduced, people started laughing in USA that, oh, this guy, Obama, Barack Obama, he doesn't know anything. He said, yeah, how can it be a private good, a public good? This is nothing. It's a private good and things like that. The costliest expenditure in the world, USA, has proven to be the worst affected country by the pandemic. Okay, now let me stop at this. Now, that being said, that health is, of course, incontrovertibly a public good, and we have to only look from that. That is the first thing. Now, as it happens in economic science and in most of the sciences, mostly, most of the applied theories and applied sciences in economics are a latecomer. And obviously, health economics is also a latecomer. It's a not new one. And because while all of us, we know that Adam Smith has started economics way back in 1776. That's almost like, 400 years. But then today, health economics is not even 100-year-old. You must remember this. If in the world, health economics is not even 100 years old, maybe 6 or 7 decades, then in India, you'll be surprised to know it's not even 3 decades old. This is the introductory part you should know. So obviously, there is another misconception and construed notion which many economists also have not paid attention to. They thought that any investment on health is an expenditure. It's not investment. That's the erroneous calculation many people had until you won't believe almost 1972. For the first time in 1972 in the world, the concept was introduced that if you spend money on health and healthcare of the people, it is a kind of investment in the national wealth, in the national product of the country. So therefore, health has become a part of budget making process very lately. And obviously, after being said all this, India is also a latecomer and very, very latecomer. After we achieved in 19, now you start about the next slide. We will go to the next slide. Vani, you unmute your, because you can't unmute your mic, you know. I have to tell you, otherwise I have to call you. Please, next slide.
Yes, sir. Yes.
You don't unmute your mic because, you know, that will interfere with my presentation.
Yes,
I have
sir. Thank you.
slide, right?
Thank
If you
you.
don't, then you can't hear me.
Yes, sir. Okay, sir.
So now you can see that health policy in India has entered very late. Health and healthcare development has not been okay. Health and healthcare development has not been a priority of the Indian economic policy for almost 36 years after independence. From 1947 until 1983, that was the time when the first national health policy was announced. And obviously, what we had was only the health service conducted by National Health Service by Board Committee, and guidelines were the basis of Indian health policy approaches. And that has been the kingpin for a long time. Next.
Yes, sir.
Now, the national health policy in the light of the directive principles of the Constitution of India recommends universal comprehensive primary healthcare services which are relevant to the actual needs and priorities of the community at a cost which people can afford. Please note this. I have not underlined, but you can underline this. That means Ministry of Health and Family Welfare, in their document, they have clearly stated that India, all the sections of the society, different communities, different backward castes, different scheduled caste and minorities. It's a segmented society where people have no purchasing power capacity and they can't afford. And that's why we have to make a health policy that takes into consideration all these issues. Next, Amma.
Yes, sir.
Yeah, the salient features of 1983 health policy were, now you can see that when we formulated health policy, it's so clear. It was critical of the curative oriented Western model of healthcare. It's not that we were not aware. Many of us, we were aware, and in the health policy, they stated this. Because Western health model is different. I can't take up the whole, I can give you at least, if not more, minimum of dozen international experiences in health, because that's been my specialization. But right now the time doesn't permit, so I'll just focus on only PPT, and whenever needed, I'll try to add, and maybe in the interaction, some of my colleagues, friends, and students, they all can ask me, question me, or clarify whatever the doubt that you have, or comment you have, or even criticism that you have. You can please advance that later after my presentation. Right now, my watch shows me that it's 11:05. So I'll try to cover this within 12 o'clock. Is it okay, Vani?
Yes, sir.
Can I take up to 12 o'clock?
Yes, sir. Yes, sir. Definitely, sir.
Okay.
We'll take
Then
time.
half an hour we can spare for discussion.
Interaction. Yes, sir.
Exactly.
Yes.
So I'll try to cover before 12 o'clock because my watch shows me that it's exactly 11:05. Okay. It recommended a decentralized system of healthcare, the key features of which were low cost, deprofessionalization, use of volunteers and paramedics, and community participation also is very important in making a health policy. It called for an expansion of the private curative sector, which would help reduce the government's burden. Actually, you should know, I said off and on, I'll try to give you different anecdotes. Let me complete this slide, then I will give. It recommended the establishment of nationwide network of epidemiological stations that would facilitate the integration of various health interventions. And it set up it set up targets for achievement that were primarily demographic in nature. Now, here we should remember that actually, in a country like ours, the access to healthcare to the public basically depends on the government policy and the government direct intervention in providing healthcare facilities across the country into the remotest areas where people are not well educated, people are not well affluent, they are, I would say rather, they are very poor. Okay, let me not be modest. They are very poor and they can't afford and they can't understand. And even now, many people live in a kind of, age old superstitions that some of their diseases they can cure through that black magic mantra, or whatever we call in our local language banamati. That's the nonsense that we have even in the so-called the most advanced country with all futuristic future looking country, but we have not left our superstitions and we have not left our obscurantism. That is a tragedy. So therefore, when we are talking about private curative sector, obviously we are handing over the innocent baby into the hands of a demon, because the process of reimbursement in insurance is not an easy task. In United States, you will be shocked to know, this is what I would like to tell you. In United States, the majority people do not know how to make a claim for reimbursement for their medical process that they have undergone. They do not know what process is actually covered under the co-payment and what is not covered under the co-payment. If that is the state of the most advanced country, the Trump's country, America, then what about us? How many people know what is insurance? That too, of course, some people have come to know about life insurance, but not about health insurance. So, when we are talking about private sector, obviously we are talking about private insurance. Okay, next one.
Yes.
The 12th plan seeks to provide a safe and healthy environment to communities. Why I have jumped? Because if I cover from plan 1 to plan 12, then I think the whole day will not be sufficient. So 12th plan seeks to provide safe and healthy environment to communities, delivering universal access. This is what again I would like to highlight with maybe a red color. Universal access to basic health services and to medicines, and regularly evaluating the health system. It also seeks to make the communities more health conscious by using the techniques of communication, behavior change, and participatory governance. Participatory governance is a very wonderful idea and objective. But first and foremost, our governance itself is absolutely meta governance. It's not at all accessible to the common people. The local governments are really devoid. And I can't get into the political issues right at the moment because that will deviate from the main topic that we have, namely the most significant issue, health. Next slide.
Yes.
Now, Government of India and the state governments have the general obligation to provide free and universal access to healthcare services and ensure that there shall not be any denial of healthcare directly or indirectly to anyone by any healthcare service provider or public or private, by laying down minimum standards and appropriate regulatory mechanism. Now, all these slides I'm trying to focus, obviously you might have realized, many of you might have realized that the burden and the responsibility of healthcare of the people of a country and a nation are solely on the shoulders of the government that is in power. Obviously, they have to look after the needs and the issues. Why? Because if you want to have a healthy economic growth, you should have a healthy population growth, a healthy population life. The morbidity and mortality are the important issues that actually take care of how much net product that you will be added to. If our working population cannot really work full time in their workplaces, obviously the amount of output that is being generated out of healthy life is cut down by that much amount of the time which they are sick, or they are not able to take care of their healthy life. Obviously, therefore, what we need, we try to calculate in terms of the quality of assured life years.
Yes.
Or quality, we call it QALY, quality. Okay, the quality assured life years that count. And when they disable, obviously, that means the amount that we subtract from the actual life years will be because there is an average life year for every nation. And incidentally, I am not coming to the nitty gritty of the per capita health expenditure of the countries. That will take a lot of time. But now, if I have to cover both COVID and pre-COVID, then obviously I can't get into the nitty gritty of those details because that will call for a separate kind of a issue. So, okay, next one.
Yes, sir.
Now, 11th plan health outcome indicators set as time-bound goals for lowering maternal and infant mortality, malnutrition among children, anemia among women and girls, fertility, raising the child sex ratio have not been fully met. Actually, at the time of independence, this has been really abominable, really kind of, it was disgusting. But right now, we could achieve some success, in particularly in terms of mortality rate, child mortality, infant mortality, and then, of course, the sex ratio still remains a problem. And all of you know, people, the parents, everybody, and they try to kill, and you every day you see it on the television screens, media, newspapers, press, discussions everywhere, that some maniac husbands try to cut open the wife's stomach to see whether there is a boy or a girl baby. This kind of a stupid thing happening in 2020. Tragic. We can't call ourselves the real great nation going forward, are we? We should be ashamed. Why this is happening? Actually, I don't want to get again into those issues, but what I'm saying, India trails in health. This is what I would like to say. India trails in health outcomes behind Sri Lanka and Bangladesh. That's a shock you should get if you don't know this. If you know it already, well, you would agree with me. That is, Bangladesh has achieved one of the best healthcare strategies when Yunus was Nobel Prize laureate in economics. Muhammad Yunus was managing, and there they introduced a lot of kinds of things. And a Bangladesh health minister, his name is, I personally know him. I met him in various conferences. He has done a fantastic dealing. And in Sri Lanka, I met 2-3 people who were in my international conference, and they have done marvels. Why? In Sri Lanka and Bangladesh, they had a different strategy. That is the strategy of making accessible the universal health care to all the downtrodden, needy, and every section. So the healthcare system in a country suffers from the inadequate funding, number one. So when you budget allocation for healthcare, you have to make sufficient amounts. This is not me saying. This has been told by Joseph Stiglitz. This has been told by Amartya Sen, our own economist, and many economists all over the world. They told that if you don't pay sufficient attention, a significant allocation in the budget resources to healthcare, to education system, you cannot progress economically forward in future. This is being well documented. I don't want to reproduce data here, though I have bundles of data. That's not time for now. So here, now social sector programs, suboptimal use of traditional systems of medicine, weak regulatory mechanisms, and poor capacity in health management. Now, our traditional systems of medicine are ruined by kind of, tarnishing them with some kind of, uh, obscurantism into the traditional medicine. The real part of the benefit from the traditional medicine, we have fantastic traditional medicine, Ayurveda, okay, Ayurveda, Siddha, and then we have uh, uh, this one, mm, Muslim medicine, Unani, okay. And then we have Unani and we have many homeopathy. Of course, that has been important into our country, but that's what I'm saying. The scientific integration of all the systems into one is not done systematically because of some vested interest in even integration there. Well, current government's best achievement is that now we have Ayushman. That's a wonderful thing. And then Ayush is a ministry that is Ayurveda, Unani, and uh, Ayurveda, Unani, and homeopathy, okay, Siddha, homeopathy, and all that. That's being made into one. And now, currently, insurance companies have also come to recognize that even if you treat from the alternative systems of medicine, your reimbursement will be taken care. Okay, but then what will happen? There are wide interstate disparities and differences between rural and urban indicators of health. That's one. See, that means we have all kinds of segmentations in the system. Okay, next,
Yes,
please.
sir.
Yeah. So the public health sector should assume roles of promoter, provider, contractor, regulator, and steward, all in one. Make no mistake about it. Somebody tells that no, you have to pay from your pocket. They are cheating you. That doesn't happen. It happens only in one advanced capitalist country in such a brazen way that even they have started realizing, and a lot of critics have come. That's United States. Okay, not even Canada. They are joining North American, North American continent, Canada. Okay, so it doesn't happen in Canada. Canada has a different system. Why? It doesn't happen in UK. It's a very close ally of USA. But then in healthcare, they don't follow the same model as USA follows. It is different. So now good referral systems, better transportation, improved management of human resources, robust supply chains, and data, and upgraded facilities should be ensured. This could be done by introducing all India and state public health cadres. For your information, we don't have that. All of you, I am reminding you, we don't have all India and state public health cadres. We have a civil service cadre. We have a kind of, administrative cadres, bureaucratic levels, but not health. And if we have started also, it's a very, very, very insignificant numbers. Now, developing a national health information technology network, streamlining regular fund flow, and ensuring accountability of patients and communities, that's still in the asking, irrespective of course, Modi's wonderful introduction, namely uh, Ayushman Bharat. Next one.
Next, sir.
Yeah.
Okay.
Now, to achieve the above reforms, establishment of National Health Regulatory and Development Authority, having a system support unit, a National Health and Medical Facilities Accreditation unit, and health system evaluation unit, which are being recommended as very important measures by the government committee themselves. Next one.
Yes, sir.
Yeah. Yeah, next one.
Next, sir.
Yeah.
Okay, sir.
Yes, India unraveled an ambitious plan, Ayushman Bharat, in 2018 to give almost half the country's population free access to health care. We should make it the largest government funded scheme in the world. The National Health Protection Mission, dubbed Modi Care after the country's Prime Minister Narendra Modi, would offer 100 million families or about 500 million people living in poverty up to 500,000 rupees of coverage each year. Well, I don't want to comment in detail about this. Right now, it still remains a starter. It has not taken off. And this Ayushman Bharat has catered only a minuscule percentage of what is being. They may say it's only 2 years. That's fine. But healthcare is the one which has to be started with utmost rapid speed, and it has to be taken care at every level. You know why? Because until now, both health is a kind of center and state subject. Both. It's not that only center will do and states will not do, and states will do and center will not do. It has to be a kind of utmost understanding between the state and the center. That's the reason why states trying to claim that it's exclusively our own program and we have formulated a better program than the center, and sometimes even refusing the assistance of the center. Whereas centers trying that states are hoodwinking the best program that we have offered, they are not utilizing, and on the contrary, they are taking our funds and trying to make their claim. This kind of political dilly-dallying going on, not just in our Telangana and center, not just in Andhra Pradesh and center, not just in Kerala and center, but many states. Right now, current situation in India doesn't call for this kind of nitty gritty squabbling between the center state relations. This is not the point to rake up. Why? Because both center and state, if they don't work together, it's really first very difficult to save. The lives of the people are getting affected. Right now, we have climbed up the ladder despite our control. Relative to our population, the number of people dying may be low, or relative to our population, the number of people who are affected may be low. But then, if you take the absolute numbers, it's going up rapidly. And right now, you all know that we have already crossed Brazil, and I think we will just take the position next to USA. It may not be too far. That will be a tragedy. Instead of controlling COVID, we are trying to, get into this kind of, uh, uh, squabbling and internal fights, and then the cooperation is not. So what's happening? The public issue is being put into the background. That's because of three reasons. Now, first and foremost, many of the governmental institutions have become very insufficient or absolutely off the track. They are not able to provide health care. That is because of many issues. And of course, the most important issue is the corruption. The corruption just not at the medical hospitals, not just at the level of, the lower staff, but also at the highest level staff, and also the political intervention each time, both by the center and the state. That is becoming a big problem. And actually, you know, uh, uh, you all know, we all have stood and we have lit the candles, we have beaten the drums, we have beaten all the plates in support of the saviors of our population, the medical uh, professionals, the doctors, the paramedical professionals, the nurses, everyone. But then today, they themselves do not have sufficient production. We don't have sufficient PPEs, okay? Personal protection equipment. We don't have. And then what we have, of course, is the liquid. namely the sanitizer. We have produced sufficient amount of sanitizer, but sanitizer can take only very, very elementary care. It cannot take. Then what all we need of? The need is that we need a kind of systematic protection. Of course, vaccine is on trial, and of course, we are claiming that vaccine will come, and how early it will come is still a question. We have to wait and see. Though, of course, a lot of progress has been done, and the Putin vaccine, that is Sputnik, I'm just using Putin for the sake of ready reference. The Russian vaccine, which is known as Sputnik vaccine, is already having a collaboration with Indian company, and they will start introducing. And apart from that, our own Indian companies, in collaboration with our CCMB, IICT Hyderabad, both, and many companies are trying to make vaccines, and they are in, of course, advanced stages of a trial and experimentation. Let's hope that will come fast, and maybe at least in the next 6 7 months. Still, we are very happy, but let's wait. Let's keep our fingers crossed. That apart, what is needed is, let us take this opportunity of COVID-19 and start reforming the structure, the basic structure of the medical fraternity, medical institution that we have in the country. Namely, we have currently what is known as the primary, secondary, and tertiary care medical centers. Now, primary care centers are now totally defunct. That is beyond. A lot of studies have shown that the primary healthcare centers in India are not working properly. If I have to produce some data, let me depend again on Jean Gilles and Amartya Sen and some more studies by some people who have done, Professor Arora in Gujarat and Himachal Pradesh. They have shown that very exceptionally that the success of public-private partnership in healthcare succeeded in hardly 2 or 3 states. That is number one Gujarat, number two Himachal Pradesh, and number three I think probably this place Rajasthan. So they have quoted that the public-private partnership always tries to make use of the infrastructural facilities, the medical equipment, the surgical equipment that is being laid down by the government, that is the public, that's our money. And then they want to take the operational benefit. They don't want to advance any investment into infrastructure because they say that once we hand over, then obviously the infrastructure will remain with the government. In this case, what I'm saying, not that public-private partnership, all people are the same. No, there are obviously some private sector people also who are oriented to public, who are giving a lot of priority. But until now, many corporates have not come forward to invest in public institutions at all. They are just trying to make managerial changes, and they are just trying to make peripheral amendments to the existing procedural uh, inadequacies. That's all. So medically, there are many things that have to be done. So primary health care, where the young graduates are being pushed, they hardly go to the villages, they hardly go to the small towns, and they stay in the metropolitan places and they don't deliver. A lot of data exists. Now the primary healthcare centers, the primary health centers, which are being the blood bone of the Indian health system, if they are totally not supported, and if their backs are being bent and they are bending towards non-functional, then obviously it's very difficult to really strengthen our system, because the secondary care that we will get only at the level of the district towns, like for example Karimnagar town, maybe Warangal town, or for that matter maybe in Ahmedabad, okay, or maybe in some kind of Rajkot in Gujarat. That's a second town, okay. or in UP or in Uttarakhand, whatever, the second class towns, or maybe in Rajasthan, Ajmer, that's not the metropolis, but that's a second class town where the secondary care is being given. And there are actually what's happening. Some main operations are performed, but super specialty specializations are concentrated exclusively in metropolitan cities like Hyderabad, like Bangalore, like Mumbai, and like Delhi, Kolkata. Okay, and still that is the same. Like for example, you think of Just Look Hospital, you have to go to Mumbai. You think of All India Institute of Medical Sciences. Though the government has promised a lot of All India Institute of Medical Sciences across the country, nothing works in the way Delhi All India Institute of Medical Science works. For various reasons. Again, let's not go into non-economic factors. So this is a problem. And then tertiary care, that's what I said, the super specialty is beyond the comprehension of the common man and poor people. Particularly the scheduled castes and scheduled tribes and minorities. And actually, you know, when we advance some kind of improved systems, even those, for example, Aragyasri in our state, previously it was in Andhra Pradesh state, okay, which was introduced by, of course, where he made a kind of, you know, a permanent name, the previous Chief Minister of Andhra Pradesh, Dr. Y.S. Rajshekar Reddy.
Yes, yes.
It's no doubt he introduced a fantastic system of Aragyasri. People who never dreamt of, you know, stepping into the portals of this corporate hospitals like, say, Apollo or KIMS or CARE, they started getting into the threshold and they started taking, you know, treatment for coronary diseases or urinary diseases, or for example, you know, even what we call kidney and other diseases. The super specialty. But then what happened? In actual practice, the studies have shown, it's published in Cambridge Journal, it's published in Health Economics, the International Journal of Health Economics, with the data. And my own papers are there where I have shown that Aragyasri was benefiting only a select few and not all. And certainly you will be shocked to know that Aragyasri was not benefiting the scheduled caste more. It was benefiting the OBCs more. If you take, so all this segmentation is there. I said in the beginning itself, we can't go into the nitty-gritty. So what's happening? This kind of programs, of course, now many people are saying that what Modi has tried to introduce as Ayushman Bharat, his critics are pointing out that he has tried to blow into a national level Aragyasri of Andhra Pradesh and Telangana. And our Chief Minister, Honorable KCR, he says that he has an improved version over Ayushman Bharat. And they are copying his program. This doesn't really take any way. Who is copying who is secondary. Okay?
Yes.
But then, as long as you put that, you know, the National Health Mission, there you have to pay certain amount from your pocket, which cannot be called complete insurance by the government. And it's a really bad thing that a country like India should depend on this kind of a thing. Then some of you may say, Professor Manohar Rao, what are you talking? If we don't put from our own pocket certain percentage, then how can government give all? My dear friends,
Yes.
I will tell you, there are not less than 6 countries in the world which don't take 1 rupee or whatever the currency that country has
Yes.
from the pockets of the people. They give entire accession to health care by their own, from childhood till death.
Okay.
Then don't we have a better model? Do we have to copy the model which is a co-payment model, namely United States? United States co-payment model is a worse model. That is the reason why we are still, by mimicking, by imitating USA, whatever is there in New York, we should be there in Hyderabad. Whatever there in Dallas should be there in Karimnagar. What is this? What is this? How can you? We have a lot of our own, inadequacies which can't be, dreamt. Dreams are not substitute for reality. Please make a note of it. Dreams are dreams. They may try to, inspire people into action, and maybe, they may garner some kind of extra votes. Vote is different, and reality, economic and social reality is different. Let's not forget this fact. Okay, then Mr. Narendra Modi's proposal of Ayushman Bharat is proposed, see, in 2018. And some of my young students in Satavahana University who are there participating, of course, my students are also joining from all the places in the country. That's what they told me in their WhatsApp message to me. If they are there, all of you, I am warning you, please show me if there is any insurance company that has come forward to join Ayushman Bharat, please.
No.
Why? Why? If Ayushman Bharat, that means there should be some insurance company to come and sponsor. You know why? The top insurance companies in our country, they have told categorically, they issued a statement in all the newspapers, Hindustan Times, Times of India, and Business Standard, Economic Times, also of course our Hindu Business Line. They categorically told it will not work out, and we are not ready to sponsor this Ayushman Bharat. Then who should sponsor? Obviously government. Why not? I would say junk the insurance companies who are really, hesitating from helping their own people, their own fellow brothers in the, civilization. Junk them. Government should come forward. They should make extra allocation to healthcare. That is the demand of the time. That is what COVID-19 is dictating to all of us. Just not economists, please. To medical doctors. Medical doctors, we are hearing that in the beginning they have tried to show, they have served, they have come in their dresses, they waved their hands, we are with you, we save your lives. But what we hear today, they are indulging in extortions from illiterate people, patients. Well, literate or illiterate doesn't matter before a disease, okay? Because disease doesn't know whether you are educated engineer or doctor. S.P. Balasubramaniam, a great singer,
Yes.
that's not leaving him. We hear that he is in a very acute medical condition. He is in a very acute medical condition. We don't know what will happen.
Yes.
And he has a plenty of money, better than us at least. So not only that, government of Tamil Nadu said that they will foot the bill of every rupee that is going into the treatment of the great singer. Well, that is of course well deserving. He needs to be saved. I want him to come back. I'm also one of his favorite, my singers. He
Yes,
should
sir.
come back. That's okay. I pray like all of you. But
Yes.
that, COVID-19 doesn't know, oh, this is S.P. Balasubramaniam. See, COVID can't discriminate there. But doctors can. They can scare people. They can terrorize people. That whoever go to the doctor, they can just, issue a threat. I think you have COVID symptom. And the guy dies and he sells his property, everything he blows it off to spend the treatment. We don't have legal and uh, kind of, law and order situation where we can criminalize these people who are trying to extort money from, this unnecessary calamity. We don't know. Until so far, nobody is jailed. We have to throw them into jail. And irrespective of his skill, because he is indulging in unethical practice, inhuman practice, he is becoming a demon. He is becoming a Rakshasa. Okay? So, COVID-19 is safer than even these doctors. That should not be the case. Okay, next one.
Yes. Okay, sir.
Next one. Next slide, please.
Yes, sir.
Yeah. Now, if rolled out effectively, the national NHPM would be a significant step toward achieving universal health coverage, a key sustainable development goal for 2030. Well, of course, now it's all being, pushed off the track. So we don't know. Sustainable development goal for 2030 will be now. Sustainable development goal for 2040, we don't know. While Modi has announced the program will be launched later in the month, experts want. Okay, next one, please. Next slide.
Yes, sir.
Yeah. Now, every year, this is a fact we should know. Every year, 55 million Indians are propelled into the poverty because of out-of-pocket expenditure. That's what I've been talking about on healthcare, primarily medicine costs. Now, let me get onto this. What are these medicine costs? Now, I would like to really, like Dr. Srivani and Dr. Varaprasad, my, long time admirers, friends, students, and all,
Sir.
you should know one fact.
Sir.
Medicines are manufactured by an industry called pharmaceutical industry. The drugs and pharmaceuticals are something which is very, very like, a black box. You know the word black box. In aircraft, there is a one thing called black box that cannot be known except, at the time of accident, we hear that people have broken the black box to know what happened. So it's mystery. A black box is, in English, it's known for a mystery. Okay. Now, what is pharmaceutical industry? Pharmaceutical industry, when they try to explain the price mechanism of drugs, there is no systematic method where it can be known by others except the company itself. Because the research and expenditure cost, R&D cost, is the company's own. Now, what we have, various methods are there. We have the Bureau of Industrial Costs and Prices, BICP, that has tried to set in what is the maximum price that should go. But then it doesn't follow that. And previously there used to be, category 1, category 2, category 3, category 4 and all. They have now been changed into category 2, category 1 and category 2. Even then nothing happens. And previously, when in the beginning, when Fatih Committee report happened in 1975, great strictures happened. The multinational corporations in the pharmaceutical industry, companies like every Indian family knows Glaxo. The baby milk that they drink is Glaxo. The small baby is giving the milk powder, that's Glaxo. That's one of the topmost, Glaxo laboratories of the UK. Okay. Now, of course, Glaxo India it is. And Glenmark is another name for Glaxo. Many companies are like this. Hext is there, Pfizer is there, all these companies are there. And they perform various kinds of research. They have different mechanisms of calculating. Now, what is happening? You will be shocked to know, until 1970, the expenditure of R&D of these companies in India, do you know how much? It was not even 0.5 to 0.1%. And their great difficulties started touching one. Even now, these top companies, they don't spend their R&D in India, they spend elsewhere. And they seal the patents that are necessary. And there was no research for tropical diseases in this country. Tropical diseases, namely malaria or cholera, or for example, these kinds of things, which are based on bad sanitation, bad, drainage facilities, and we don't have good drinking, safe drinking water. So all these things are not born because of in these countries where the development is not up to the mark. Even now, well, we have no assured safe drinking water in many villages in this country. Today, even now, many of the TV channels, many of the newspapers carry the stories that ladies, because, ladies are the people who have to get a pitch of water. We can't get, no, all our Hercules males, they have to show their muscles only to, rape and, terrorize women. They don't go and carry the vessel themselves, and they don't get, a pitch of water. But ladies, they carry the vessels on their shoulders, go miles of distance and take that water and bring that water and cook and give for food to everybody, the great male population as well as Indian female population. Okay. Now that apart, what I'm saying, when these facilities are not at all being met, then obviously this kind of gender, inequalities persist. Apart from that, we don't want a female child. Okay, that also being considered. Then what will happen? Now, these multinational companies, they never thought of, Ross, who was a British scientist, Sir Ronald Ross,
Yes.
where we have in Hyderabad that Malarial Research Institute in YMCA, Narayanguda.
Yes, sir.
So after that, nobody came forward to really put any investment in malarial parasite or anti-malarial drug. You will know that all the anti-malarial drugs are being produced in India by the Indian companies. Of course, they manufacture some of them, but very minor percentage of that. So even today, the highest percentage of R&D is by Indian companies like Dr.Reddy Laboratories, which is again in Hyderabad. Okay. So this being said, what I'm saying, the medical cost that is being done includes a lot of input cost, the raw material cost, where we call it as API, active pharmaceutical ingredient. Yeah, you are going back and forth.
Sir. Just press it.
Yeah. Oh, no problem. I'm looking at my watch. 10 more minutes.
Just I press on that my finger, sir.
Yeah.
Yes, sir.
So what's happening? The medical costs or medicinal costs are not accessible to people at all. They are exorbitant. And that will be true for every section. But obviously, the people with insurance and people with, good capacity, they can afford to pay the costs. But not so with others who don't have ability to pay, and those who don't have access to healthcare or insurance, that cannot be covered. Now, added to this, what we have done, one good thing is that pre-COVID situation, what we have, the best thing is that thanks to Jaisuklal Hathi, the great chairman of this pharmaceutical committee that was appointed in 1974, thanks to him,
Yes.
our Indian pharmaceutical industry has really taken the grounded roots, foundations in such a way that they could tackle. And then, of course, the process patents were not recognized. The process patents were recognized, but not the product patents. Product patents were, that is because of IPL, Indian Patents Law 1970. With that act, Indian pharmaceutical industry really could grow from leaps and bounds, and it has really become competitive and internationally competitive in such a way that, it has started giving challenges to top class companies from USA, UK, and of course, Switzerland and Italy. Okay. In India, we don't have many of the Canadian pharmaceutical companies in this country, but maximum we have is American, British, and German, of course, and Swiss, and then Italian. These are the companies that we have, maximum number of companies, whatever the names that they have. So these companies were made to really, but in the beginning, American pharmaceutical executives and even the USTR, that is United States Trade Relations USTR representative, they started accusing Indian pharmaceutical industry that these people are copycats. That has proven to be shit. And now American president himself is saying Indian pharmaceutical companies are in a position to generate vaccines first in the world. He is giving, a certificate to Indian manufacturers like, Cipla, like others, like Dr. Reddy Laboratories, that, we are hoping that the COVID-19 vaccine will come from India, which can be reliable and which can be used in the world. So that's, of course, a great pride that we can think of. But then, if we don't utilize this opportunity in full, the real kind of, golden opportunity that we have in our hands, we will be squandering it away if we don't plan it systematically. And for that, I mean, we need to not only build up, we have to build up from the scratch, from the structural changes. We can't get any other opportune moment than this, because people understand in the current situation of pandemic that there is a need to revamp the whole system from its basic rules. Let's make that. Next slide, please.
Yes, sir.
Now, India has allocated $1.54 billion for the scheme with insurance payments to be shared. Okay, this is about Ayushman Bharat. Okay,
Okay, sir.
right. We will go to the next one.
Okay, sir.
Yeah, next slide. Yes, the private sector has grown exponentially over the past decade and currently provides almost 80% of outpatient, 60% of inpatient care in India. India's NHP called for the strategic purchasing of private care to bridge critical gaps in public health facilities. Government purchasing is intended to create a demand for the private healthcare sector in alignment with public health goals. The policy states that such a strategic purchasing would play a stewardship role in directing private investment towards those areas and those services for which there are currently no providers or few providers. I'll comment on this next one. Next slide.
Okay, sir.
Now, the private sector in India has been able to grow at an unprecedented pace because it remains largely unregulated. Please underline here.
Unregulated.
Woman Kurian, public health fellow at the Observer Research Foundation, an independent think tank in India, says the private sector exerts huge economic and lobbying power in India. Make a note of this.
Yes, yes.
Basically, patients have no idea what procedures they need and when you really don't need a surgery. That's what I told in the beginning. You are convinced by the doctor that it's necessary. While the doctor gets a cut from the hospital chain, he said, there is no accountability, he added. Next one, please.
Yes, sir.
The public health system, particularly in rural India, can be regenerated. Two things that are missing in public financing and political commitment.
Commitment.
You need the leader for the farmer. This is Robert Yates, director of the UHC Policy Forum at Chatham House, United States. A large proportion of out-of-pocket expenditure is people buying drugs for chronic diseases which are burgeoning with the country's changing burden of disease. Next slide, please.
Yes, sir.
yet says India must invest in primary health care. Please make a note. That's what I told in the beginning. Essential to keeping access to health care equitable and affordable. Though the initial health policy proposed installing 150,000 health and wellness care centers across the country, yet said those could fall to the wayside amid plans for the health protection scheme. Okay,
Yes.
next slide, please. Now, how will we achieve universal health care by 2022? And let me tell you,
Yes,
this
sir.
I made before COVID, please. So I will make changes once I present it. There are a number of challenges to be overcome to achieve USC by 2022, such as the largest disease burden in the world, reproductive and child health problems, malnutrition, issues of gender equality, poor availability of trained human resources in health, inadequate research to achieve health care for all, commercialized, fragmented, and unregulated healthcare delivery system. Next slide.
Yes, sir.
Other challenges, inequalities in access to healthcare, rising aging population, social determinants of health, such as poverty, illiteracy, alcoholism, etc., to frequent and too severe natural disasters, lack of intersectoral coordination, and political pull and push of different forces and interests. Next. Through a paradigm shift in the planning, implementation, and monitoring of healthcare delivery, there can be a way forward for ensuring universal healthcare for India by 2022 by according priority to the needs of the most deprived groups, improving non-medical preventive health action related to employment, incomes, food security, water, and sanitation, removing constraints in the health seeking behavior of health people, improving outlay on health to 5 to 6% of GDP at the rate of rupees 2,000 per capita per year, augmenting the existing network of healthcare delivery system, especially in rural, tribal, and inaccessible areas. Next one.
Yes.
Intensive use of technology structure for public health workers, reorienting medical undergraduate education toward public health and sustained intensive health education campaigns, the key areas of concern in fulfilling the objectives of achieving USC by 2022, which remain to be addressed include broad agreement on the financing model for healthcare delivery, type and duration of training for senior functionaries in public health, entitlement package, and the cost of healthcare interventions, enactment of National Health Bill 2009 as Health Act, and declining state budget allocations for public health all to be curtailed. Next one, please.
Yes, sir.
Okay, thank you. Let's close the PPT and get
Yes,
into
sir.
the discussion. Okay. Now, I think, this paper has really caught attention of the world like anything. Just this morning, I got the citation from Academia Edu that my paper is being quoted for the 381st time in the international journals. I'm so happy about this because I prepared this for a publication in international journal. It's published already and people have quoted. I'm happy that, people in medical journals also quoting my paper, and now floor is open for discussion. Exactly 12
Please.
o'clock.
Yes, sir. Yes, sir. Yes, sir. Dear participant, please ask the questions regarding the issue. And okay, it is a discussion forum to you. So please unmute yourself and speak towards sir. Anyone?
Sir,
Yeah.
sir,
Varaprasad.
sir.
Please.
Sir, sir, there is a saying that COVID-19 is self-created and it has been promoted by some countries and some pharmaceutical companies. That's one part of the question. Second question, in your finding about health scheme which is been implemented in government of Telangana and previous Andhra Pradesh, especially it has benefited more OBC communities. Is there a survey of such kind?
We have done a survey.
This is to sir. Okay, sir.
We have done a
Sir,
survey. We have published.
Okay, sir. Okay, sir. And
These
these two,
data.
yeah. These two questions. Later on, we can have a discussion.
I will the first. This one I will give you first because you are asking database questions. So this will be the first one. In the survey we have done, we have shown that minorities are the least benefited out of Arogyasri. You should know that in Andhra Pradesh and Telangana. They are the ones who could take the least benefit in Arogyasri. Minorities. Then next, of course, scheduled castes. The most benefited are OBCs. About your first question, Varaprasad.
Sir.
There is no proof of what you are talking. It's all cock and bull story.
Sir.
There is no evidence at all.
Sir.
Whether China or any other pharmaceutical country, whether it is created by a company or a country, that's not the current, question that can really solve the pandemic.
Sir.
Suppose, let's say, as some lady was, appearing in some TV channel and saying that I worked in Wuhan laboratory where it was being made. Right now, I think world over there is an anti-China campaign is going on. And that's okay. Let's not hold any brief for any country or any individual or company. That's not our interest at all. Because it's not that, how it happened, we can't comment right now. And I think, as an economist, I don't want to get into that framework at all. But what is important is that we must try to tackle this. Varaprasad, you should know that even today, 95% of our requirements, I would say rather almost 100%. In pharmaceutical making, we have what is called the basic drugs and formulations. Okay. Unless you have the inputs for basic drugs, the generics ones, okay. Active pharmaceutical ingredients, that is API, you can Google it and check. Active pharmaceutical ingredients, we have to depend entirely on China. If our present government or Modi as a prime minister, he decides to stop API from China, then all our companies will close down, shut down. That's it. So let's not mix politics and with economics. They are separate, these are separate. So what we need to do is like our structural reform is irrespective of China, irrespective of America, irrespective of multinational corporation. What I am suggesting, some reform process in our own country, in our own basic structure of the industry, and then I told you that the healthcare is the most unorganized, unregulated sector, and American economist Yates is commenting on that from the Chatham thing. Okay. Okay, next one. Varaprasad, thanks for that.
Thank you. This is a wonderful lecture, sir. Thank you very much. Thank you.
Anybody? Anything you can, like, Varaprasad has taken a cue. If you think that, some even other kinds of issues can be raised, like, can there be a COVID-19 vaccine? If so, then how effective it is? Because, all the great people are dying one after another. Celebrities are dying. Dean Jones died of heart attack anyway, not because of COVID-19. Let's not mix up. He died because of heart attack. But many people are dying because of COVID-19. We are not able to control that.
Sir, one student is asking a question. He is put into chat, live chat.
Yeah, please take up. Please
sir,
take up that.
but why the poor people is not getting the health benefits? What we can do? She is asking in the chat.
Yeah, see, my main concern is the same thing from the beginning till the end. What I maintain, that the poverty-ridden poor people from different communities, sections, regions, and
Yes.
religions, okay, they are not getting the benefit. That's because of various, non-economic reasons.
Yes.
Basically, because of unprincipled people, both professionals as well as politicians, and unholy nexus between both of them. And it's hierarchical. See, you will see every day yourselves, and unless that's the, that question is related to the whole economic system, social system, and the political system. So that's a very broad question. Why it's not reaching? That question is valid not just today. It is valid, what we say, counterfactually from 1947 onwards. We don't know how many years ahead it will be valid. We don't know. Maybe the same question will linger on. And it will come in many debates like that we have in our webinar today. And youngsters like you may have to really take up the same question and answer from different dimensions. Yeah, you can read out, Srivani.
Yes, sir. Yes.
Because,
Yes, sir.
I want to be able to
Yes,
look
sir. I
into
can
this
read.
chat box,
Okay, sir.
because of my poor vision or whatever.
No problems. I can share it. So one more person is asking, All India Medical Services proposal is good, but
Yeah.
it should be implemented to achieve health for all.
Yes, exactly. That's what I said. Let's hope that it will take roots. It is a non-starter. It has not started yet.
Yes.
But it's a very good proposal. Yes, he's right. I agree with him.
Yes.
Yeah. Lot of time.
One more person is asking, Manoj Kumar from. His question is: Present unemployment is due to coronavirus. What must be our future plan for it?
Manoj, you are not correct. Our unemployment has been there before Corona also. Yes, you are right. Coronavirus has escalated unemployment situation by many folds. Maybe you are right. We are already in that kind of economic stagnation for some time. And yes, Manoj, you are very correct that Corona has accentuated that kind of a situation, both unemployment wise and also economic stability wise. People became poorer, poor people became poorer, poorer became poorest, and rich became richer sometimes. See, this is where Corona has discriminated really badly. Even Corona has become discriminatory. Why? Because rich knew how to make money in the COVID times also. They made a lot of money. Poor didn't know what to do. Mostly migration labor and other people who are seeking temporary employment, they really lost their job, their lives. Why jobs? They just came on roads, You have seen, all of you youngsters, on television, that pregnant women dragging their carts and holding another child in, their lap, and walking miles and miles, maybe sometimes more than hundreds of miles. What a tragedy that we are in. Yeah, I agree. Yes, but COVID has not created employment, it has escalated. That's true. We were already in no better employment situation. We were hoping that it would probably. But what happened? The facts, according to Government of India, is that our GDP has fallen in such a way, and our unemployment rate has gone in such a way, that we have gone back into pre-liberalization period of 1991. The unemployment rate has gone down. It's fallen in multiples, and then poverty levels have gone down to where we were claiming that that BPL, below poverty line levels of 1991. It's a tragedy. Yeah, I agree with you, Manoj.
Sir, one more question from Kavita. Government is investing money on healthcare system year by year, but the health care
Please
benefits
come
is
again.
not
What?
reaching to the
Please come again. Please read again.
Sir. Government is spending money on a healthcare system, but the poor people is not benefiting. Why? So that is related to previous question also. Same.
Yeah, I think you see this covers in the previous one, but I'll answer Kavita also. Let
Yes,
her
sir.
not feel unhappy. See, Kavita, what happens? Spending healthcare is different. What we are spending is peanuts. Our budgetary allocation of health sector only touched last time more than 2%. It's a tragedy.
Yes, yes.
Even last year it was less than 1.5%. Because, and in COVID times, we have not increased any extra allocation to health sector. This is so. One thing is, yes, we are spending, but that's not sufficient. The government is spending on healthcare, but that's not sufficient. Second thing, the structural allocation of health expenditure or health allocation is not categorized where to reach, what is important, where to necessary. They're always saying that, let's go into PPP mode, that is purchasing power, I mean, this one, sorry, private public partnership mode. Public private partnership mode, they always want. But I told you, PPP is no good. It's not always commendable. Even our Honorable CM KCR of Telangana state also thinking of PPP more. I don't know. We hear that he has a lot of wonderful, well-educated advisor with him, and they advise him on various technical issues. And he himself is a person. He has many very good understanding. But why he is not seeing this, I don't know.
Sir, one question from Adina Rayana.
Okay.
Why the government is a provider free treatment to all the COVID-19 patients in private
Exactly.
hospitals?
Exactly. I agree with you, Adinayana. Yes,
Yes.
I am with you. The government should make free payment to anybody who is affected by COVID. If they are charging from the patient even the minimum amount, I don't support. This is my personal opinion. So there I am with you, Adinayana. Yes, government has to provide free medical care to the COVID-19 affected people. It is the duty of the government. Yes, next one.
Next.
Sir,
Yeah.
can I ask one more question, sir? Please.
Yeah, please, Varaprasad, go on.
Sir, you initially told in your speech that you are going to elaborate on the findings of studies on Karimnagar and Warangal regarding health issues.
Okay.
If you could, please.
Yeah, that's a wonderful. Yes, this I think I should thank Varaprasad for this question.
And no, sir. No.
Because I missed it. Yes. See, we have taken, some data from Warangal district and some data from Karimnagar districts. Let me take up the region where we have taken. It is Mulugu Etunagaram, okay, of Jaishankar district in Warangal. I mean, old Warangal district, okay, because Jaishankar district is itself, Bhopalpalli is a separate district, okay. So I'm talking in terms of the, because we're very difficult to remember 33 districts and speak in that line, unless I look into the data. So that one, and in Karimnagar, that is old Karimnagar, United Karimnagar district,
Okay.
we took Mantri and Godavari Khani area.
Sir.
In these two regions, we found that actually the basic medical facility access is not there to tribals at all. And we have taken the Chenchu tribes of Bhopalpalli region, Etunagaram region.
Sir.
And then we have tried to take the data from, what are kind. You will be shocked to see that, the tribals, before they reach, they don't know that there is something called a primary health care center, that there is a doctor, there is some medical system.
Sir.
Forget the government hospital and all that. This is where now, how can they take the benefit of the government scheme, whether it is Telangana state or whichever state, medical kits and, Kalya, what is that, Lakshmi?
Lakshmi.
Yeah, KCR kit and another thing is there, no? So all this, they are not aware at all. And incidentally, the region I am mentioning is a region of, former speaker of Telangana State Assembly.
Sir.
And probably after his effort, there was some kind of, improvement in the lives of the Chenchus in the district. You have to acknowledge that. But the poor fellow who made efforts to improve the condition of the Chenchus in that place, he is not even being elected. Hey, well, leave that. We are not interested in that. He didn't win the election at all. Now going to Mantri and Godavari Khani, okay.
Sir.
It is the most ill-treated regions in previous Karimnagar district, the United Karimnagar.
Sir.
Because I know Mantri is, I think, maybe a district now.
Sir.
I know Godavari Khani is a district, but Mantri?
No, it's not a district, sir.
Okay. It comes in which district now?
It's part of Peddapalli.
Peddapalli, sir.
Okay, Peddapalli district. So these regions, Peddapalli and Mantri, are also equally affected. There again, the most, affected people are the minorities and scheduled castes. You asked me a question before that. Do you have data about OBC are getting the benefit? Yes.
Sir.
We have categorical data that OBC people, out of the sample that we selected, the maximum benefited people are OBCs.
Sir.
Not the scheduled castes and not the minorities. The ranking stands the same. You can say after OBCs, next scheduled castes, and after scheduled castes, minorities. Normally, in other benefits, the other schemes that you take, minorities are sometimes better than scheduled castes. Why in this case it's like that? It's puzzling, So in Warangal district, and Karimnagar district, where the focus we have actually, if you take, I don't know, I have not taken, and my students now who are doing in Odisha,
Sir.
in the villages of Odisha, they have a clear-cut data about Odisha, what's happening there.
Sir.
And I can just give you what's happening in that. Well, what I thought, the time is short, so.
Sir, no problem.
I was keeping ready my data.
Sir, sir.
Yeah. Now, what's happening? In Odisha, in Dhenkanal and other places,
Sir.
almost 12% of the scheduled castes
Sir.
in those populations,
Sir.
they are either crippled or in a very bad medical condition, or some of them are even on the verge of the death because of
Addis Ababa University, Addis Ababa, Ethiopia.
inaccessibility of healthcare. And see, actually, Naveen Patnaik has a very big name,
Sir, sir.
and normally he is being projected as a very positive man, taking
Sir.
care of the interests of the poor people.
Sir.
But why, when it comes to medical care, nobody
Sir.
bothers? Why? Because as long as you are good and speaking, you are healthy, nobody bothers.
Sir, sir.
And when suddenly somebody falls sick, then particularly in those households, the households that I'm mentioning, namely scheduled castes, they don't
Sir.
have property to sell to meet the expenditure of medicines or medical care.
Sir.
That's why I said there has to be a structural reform. And previously, I think his name is Adhanayana. He said
Sir.
that if people who are affected by COVID-19, I am the
Sir.
one who strongly advocate 100% expenditure to be made by the government.
Sir.
Now,
Yes,
whether
sir.
you pull it from the corporates, whether you pull it from the private sector, that's your lookout.
Sir, sir.
Like, our honorable CM, he has told the finance minister, or for example, Harish Rao, the finance minister, he told the center that why should
Sir.
we borrow from the banks? You borrow from the banks and give it to us.
Sir, sir.
The same question I am posing to our honorable finance minister of the state and CM of the state. Why don't you spend yourself? Then you borrow back or whatever you don't want to do. First, you allocate from our resources and meet the expenditure of the needy people. I'm posing the same question to them.
Sir, sir.
Okay.
Sir, sir. Thank you. Thank you.
Thanks for this reminder, Varaprasad.
Thank you. Thank you. No problem. Thank you. Thank you.
Sir, one question, sir.
Yeah.
So, now present the government is investment on public health care system. Is it enough to meet the requirements to the all people in the society, sir?
Oh, no, not at all.
No,
What
no.
I'm saying, okay,
Sir.
at least you increase by certain percentage, not more, because
కొంచెం నంబర్ అయితే కాల్ చేయరా
ఎవరు అని అడుగుతున్నా.
Yes, sir.
somebody should mute their
Yes, sir. I muted.
microphone, please. Can I speak now?
Yes, sir. You speak, sir. Now I muted.
Yeah, Srivani,
Sir.
see, the moot question is, like how much should spend? At least let us go by, the international standards.
Okay.
We may not be of the level of, the topmost spending people, but at least our allocation to the public health care, public health expenditure should be at least double than what it is now. Why we are doing that? What is preventing? When we are allocating everything in the budget, why not health? Now, don't we learn lessons from, the current situation where our lives are at stake? I agree with KCR. First, we have to be alive. Yes, sir, you are right. We have to be alive. Then we can do anything, economic progress and all. Then why don't you do that? To keep us alive, you spend more. Not just state government, because, it's a both, state and central subject. I am also addressing both. Honorable Prime Minister Modi, why not he spend? Why Ayushman Bharat? It's a great one, because in independent India, the credit has, you see, we have to give credit to Nehru, we have to give credit to Indira Gandhi, we We have to give credit to Modi also. And of course, we have given credit to Manmohan Singh. Why not? Because we are economists. We
Yes.
don't need to really get into the political matrix of these, because that is a particular party, this is a particular party. It's okay, fine. The change in, see what happens in Western countries, the change in government doesn't really give up the path pursued by the previous government. Of course, now Trump is showing a different way. He is trying to attack Barack Obama. Even now, he is not in power.
Yes.
I don't know what is bugging him, but still, in majority of the country, you'll be surprised to see in the capitalist countries, the best capitalist healthcare. How many of you know? Well, anyway, let me not waste time.
Yes.
See, the best capitalist country which is providing the best healthcare is number one, Norway,
Yes. Yes.
followed by Denmark, followed by Switzerland, and then, of course, Netherlands.
Yes, sir.
All these countries, and they're actually in country like, uh, Denmark and Netherlands, I'll tell you, this I have told in some other seminar also, there is a need to make health card, like your Aadhaar card, PAN card. You make a health card of every individual. Therein, the health history of every individual is documented there. Suppose Dr. Srivani goes from Karimnagar and she goes to, let's say, Bhubaneswar, very neighboring state, Odisha, and she has some stomach ache. She will go there and she will go to the doctor. Maybe ladies prefer a gynecologist, doesn't matter. She will go to the gynecologist there and show her health card. In countries like, Germany, Switzerland, Netherlands, Denmark, and all those Scandinavian countries, what happens, you insert the health card in the computer,
Okay.
your health profile will appear. Srivani, oh, she had a thumb injury at the age of 6, for which, she has been given a slight, hairline operation and then the bandage, and these drugs were given to her for, cure.
Okay. Okay.
Like this, at the age of 16, she had this, at the age of 18, she had this. And of course, I'm sorry, God forbid, I don't think you will have any medical history at all. Srivani has been all through excellent health condition. Wonderful. That's okay. It's only an example. What I'm okay,
Example.
my health card is there. Okay, he suffered this, he suffered that, he suffered that. He was an asthmatic, but his asthma has completely vanished. Why? Because of, the kind of, system that you follow. Otherwise, breathlessness was in the current COVID, probably I would have been the victim.
Yes.
So, so the health card, once you insert anywhere in the country, any hospital, any clinic which is being certified by the government of that nation, it should carry everything. And then the physician or the surgeon or whoever wants to diagnose and give or suggest a procedure or a medicine, then he can do with a very minimum work. He need not. Then will we develop that? That's what I mentioned in my before finishing the second slide. That is national data network.
Yes. Yes.
That's what I mean.
Mm-hmm.
What I mean, national data network, because every slide we can't explain like these details, because already it's 12:30 now. I'm watching my clock right in front of my eyes. So unless you say that there is time we can discuss, I'll stop here.
Sir, sir, Syed Kazim is raising one question, sir.
Yes.
Why India remain unsuccessful in tackling COVID-19 pandemic in better way in comparison?
Who is this?
Syed.
Okay.
Syed. Why
Okay.
India remain unsuccessful in tackling COVID-19 pandemic in better way in comparison to neighborhood countries Sri Lanka, Bangladesh, and Pakistan, who were lagging health infrastructure?
I think, Syed, I mentioned Sri Lanka and Bangladesh.
Yes, sir.
I never mentioned Pakistan.
Right, yes, sir.
So, Syed, you should know Pakistan is in a very dire state and they cannot really tackle COVID the way we can, number one. And Syed, you should know I mentioned Sri Lanka, Bangladesh, not for COVID. I talked that for, the medical institutional reforms that they have taken. Okay. He is there in the line. Mani, can you hear me?
Yes, sir. No, sir. No questions is there, sir.
Yeah, no, wait. So,
Sir.
you should know that Sri Lanka and Bangladesh, they have really done better in terms of the medical institutional change.
Yes, sir. Yes,
I never said about COVID-19.
yes, sir. Yes, sir.
And now about why we failed. Syed, you are wrong. We have not failed. COVID-19, we are really tackling very well than many countries, including countries like France, Brazil, Germany, and even United States. But then, this is not sufficient. We need to really speed up our system. We can do miracles. Okay? Because when Trump has asked us that, we should supply him immediately, this medicine. We supplied.
Chloroquine.
Yeah? Sorry?
Chloroquine.
Yeah. Now, that chloroquine and all those medicines we supplied, and sanitizing liquid also we supplied. That's how our pharma companies are flourishing today. Okay. So, yes, we were not better than Sri Lanka and Bangladesh in terms of the health indicators. How to construct a health indicator index? There is a method. We can't get into that debate of, the basic theory. Basic theory has clearly given us how to construct an index, how to measure the health status. What is health status? How do we define the health status? Excellent definitions are there across the world. And, well, some of the young assistant professors, associates, lecturers from degree college and other colleges, apart from the students and research scholars, I mention you, if you get time, you kindly refer to the book, the basic book by, this is one of the best quoted books around the world, which I am giving you. Okay. And this I have taught to the students of international student community in Nairobi. When I was in Kenya, I taught this to the students coming from at least 8 nations. Okay. I taught health economics there. And there I was following this textbook, which I have started introducing in my department before and school now, University of Hyderabad. This is called Economics of Health and Healthcare. That is the title, The Economics of Health and Healthcare, written by Sherman Folland, Alan Goodman, and Miron Stano. These are the 3 authors. They are popularly called as Folland Goodman Stano, FGS for brief. Folland Goodman Stano is a highly referred book, highly studied textbook around the world in all universities. All the 3 are from USA, the experts in health economics and health policy. Then I can give a big list I have, because I told you I have what I should say, I have a mine of resources on health apart from the specialization that Vani has had taken the pains to read out my unwanted biodata because that doesn't help you all. Well, it's only a gesture. That's because of her love and affection. That's okay. I accept it. Most of it, I know you won't be interested in that. But then, what I'm saying, health, of course, has remained a forte with me. I'll continue. And of course, as I said, as Vani said, I think my book will come. I'm trying to speed up. Let's hope it will come in a short while. And before, there is a competition between COVID-19 vaccine and my book. Let's see who wins.
Hello.
Yeah.
Good afternoon, sir. I'm Dr. K.Srivani from ICWI Law School speaking.
Okay.
Sir, you were talking about the list of books on health economics.
Yes.
And can it be possible to know the list of books, sir? Just now what you have mentioned about economics of health and healthcare. In addition to that, sir, could you please suggest some more books, sir, since you have the list?
Kesri, you please take my email from Dr. Srivani and
Okay, sir.
write to me. I think it's not possible to give the list in this presentation, and I'll
Okay, sir.
certainly be glad to share with you.
And sir, actually, why I am asking is I too worked in Ethiopia, sir, and I was teaching health economics
Oh,
in
wonderful.
Haramaya University for almost 20 years.
Oh, great, great, great.
So I heard about your
Very happy
teaching.
to know. Very happy to know about that.
Thank you, sir. Thank you. But right now I am in Hyderabad because of one of my child's education, who is in the intermediate second year, and I'll be here for another 2 to 3 years.
Okay.
So in that connection, I hope she will be able to share your email to me, sir.
Srivani, just look into her, Dr. Kesri. If you have her email with you, you please forward it to me. Then I'll see what can be done. Okay.
Certainly, sir. Sir. Thank you very much, sir.
Thank you, Dr. Kesri. I hope all our participants are not feeling hungry. Then we can continue for some more time. Otherwise, Srivani, you are the convener. You have to take a decision.
Yes, sir. Shall I stop, sir?
No, I am not saying anything. Because, if nobody is coming forward, like, the last one, Dr. Kesri, who came forward,
Yes, sir, yeah.
and she gave me an additional information that you see, she was there 2 decades.
Yes, sir. Yes.
But when 2 decades covers, I think, my area.
Yes, sir.
That means my period when I was there. I don't know how I missed her.
Okay, sir. Definitely, I will share your email ID and the whatever the
Because
references are.
Dr. Kesri says she was in the university, that of course I know very well. And
Yes,
I was known almost to all places in Ethiopia because I was in FB, Faculty of Business and Economics, at Addis Ababa University. I was in the capital. So no problem. But anyway, it's okay. Good to know her. So if there is anybody also here who wants to comment or maybe clarify, you are free. Please come forward. Otherwise, as you said, Dr. Srivani, I think it's 12:40. Maybe people don't want to say, but they be feeling hungry. I don't know. You
yes,
can
sir.
check with them whether to continue or close it, and then you take a decision, please.
Close it, sir. The time is also scheduled time is also closing, sir.
Yeah.
Okay. So I am very thankful to you, sir. As a, such a wonderful session we have over here, and the Satavahana University is happy to, and
It's my pleasure. Like coming back home.
sir,
And as Varaprasad has told, like, many times I came there because I started there,
yes,
Karimnagar.
yes, sir.
Yeah.
So, your love and affection of this university. You had a vast experience, and you have elaborated the so many issues related to the health. And so it is a way, I hope the knowledge obtained by the participants and me also. Sir, thank you very much, sir. Have a wonderful session, uh, and have a great day we have from for you have in this webinar as a resource person. uh, Thank you very much, sir, and thanks to dear all the participants and research scholars, students, and professors, assistant professor lecturers of various institutions and various universities of all over India.
Just
And
give me 1 minute once you close.
yes, sir.
Yeah.
Thank, thank you, sir. Thanks to all who attended the program, and thanks to resource person, and thanks to the principal, vice chancellor, registrar for giving an opportunity to conduct this webinar on this issue. Thank you, sir.
Dr. Srivani and all the participants here, my esteemed colleagues, distinguished people who are present and who are not present, who have spared your time, who have been very patiently following my presentation. Thank you all. All of you take care, stay safe, stay protected. Thank you.
Thank you, sir. I hope you bless your blessings always on me for enrichment of my knowledge and community of teachers' knowledge, sir. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you, Varaprasad.
Thank you.
Thank you. Thank you, sir.